السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. I would like to thank really the organizer and the supporter of this meeting, Saudi Heart and Normal Disc, for their kind invitation and kind preparing for such important talk. I would like to thank you all for joining us and thank Professor Khalid as well for joining us for this important meeting. The aim of this talk to unraveling the cardiovascular inflammation in ASCVD. As you know, we are really facing a problem in our life with coronary artery diseases because before we start, let me just remind you that we will scan this now. If you can all scan this code, and this code will be basically a few questions for your knowledge. I want you to try to answer them at the beginning of this meeting, and then to Dr. Khalid as well. Professor Khalid will give you the same code to be scanning again to see how your knowledge about how much you gain knowledge from this talk. So we talk about the burden of cardiovascular disease is really unfortunately very common worldwide. Globally, it's the leading cause of death, and cardiovascular disease constitutes a financial burden for healthcare systems all over the world. In the year 2023, we have 20 million people died from cardiovascular disease. That means every 1.5 seconds, we have one mortality from cardiovascular disease. And in the year 2023, 650 million people are living with really cardiovascular disease, which almost doubled since 1991. And the kingdom here, we have really a very high prevalence of cardiovascular disease. And the deaths here almost 45% from cardiovascular disease. So really we're facing a global problem that we're trying to help to reduce this burden, which have been reflecting on really on many societies. Really, the problem here is that we have, despite all our current medical therapy, all advances, all the using of the different medications, still have residual risk. And this residual risk mainly reflected on inflammatory risk, which really has been not really covered so far very well. We have really an unmet need to treat this inflammatory, because now inflammation is really the main issue which have been really not dealt well over the last years. We have some help and hope to improve mortality by controlling the cholesterol, the thrombotic risk, and triglyceride. And still we have a way to go, but we have still high residual risk, and definitely inflammation is the most important one part of the story. And we are going to see in the future the treatment of lipoprotein A as well. As you know, in randomized control trial, almost 46% of patients have inflammatory risk despite lipid management with statin and PCSK9. If you look at Prove It, Improve It, and Aspire 1 and 2, including patients with or at high risk of cardiovascular disease, we can see that 46% have high inflammatory risk. This will be pure inflammatory risk in 33%, and mixed with high cholesterol 13%. So in high inflammatory risk was found in 46% of patients after high intensity lipid lowering therapy. Despite all this improvement, we have still the inflammatory marker risk persists. And if you look at this major clinical trial, prospective global world study, the Poseidon trial, which they look at the prevalence of cardiovascular inflammation, that means the high sensitivity CRP, more than 2 milligrams per liter, and it's involving 18 countries in different continents. Almost 19,000 patients were involved, and really they gathered demographic and clinical data in individuals with ASCVD as well as heart failure. And they grouped them into 4 groups: those with ASCVD and CKD, and this will be almost 384 patients per country. And then we have ASCVD without CKD, which will be again about the same number. And then we have heart failure with preserved ejection fraction, or heart failure with mildly reduced ejection fraction, mid-range ejection fraction, again the same number. And we have heart failure with reduced ejection fraction. And they look at the primary endpoint was to estimate the prevalence of cardiovascular inflammation, defined as HSCRP more than 2 or equal to 2 milligram per deciliter in a predefined cohort people with ASCVD and heart failure. The secondary objective, we're looking at interleukin 6, certified as again by high CRP, and to examine the ANT-proMP. Now, the age of this patient were from 18 and above, and the diagnosis with ASCVD and heart failure. It was cross-sectional study, including during routine visit, and they were done in a primary category clinic outpatient. Look at the data here. If you look at the ASCVD and CKD cohort, if you look at those who have combined ASCVD and that means coronary disease and CKD, you can see that almost 40% have the high inflammatory marker. If you look at those with ASCVD without a cardiovascular disease, without chronic kidney disease, again, you can see that the prevalence is about 23%. That means this trial that cardiovascular inflammation affect almost 2 in 5 patients with ASCVD plus CKD. So that patient with coronary disease and peripheral vascular disease, whatever they have disease, plus CKD are really having higher incidence of inflammation. Now, if you look at heart failure and you group them into three groups here, those with the preserved ejection fraction, mildly reduced, mid-range, or reduced ejection fraction, it's interesting that all of them have the same prevalence almost of the high CRB, more than equal to, and this really has been across the three group of heart failure. And this reflects that in heart failure patient, 2 in 5 have cardiovascular inflammation. Again, a big burden of a disease in a patient who are at high risk for cardiovascular mortality. So from this trial, we can see that in almost 90,000 individuals involved from 18 countries, its high-quality study provides contemporary global estimate of the cardiovascular inflammation defined as CRP more than 2 among patients with ASCVD. Now, cardiovascular inflammation is common, affecting almost 2 in 5 patients with ASCVD plus CKD, and as well involving almost 40% of patients with heart failure, regardless of the ejection fraction. And this is again 2 in 5 patients with cohort of heart failure have inflammation. The finding of this trial highlight the widespread nature of cardiovascular inflammation in ACPD and the importance of its high sensitivity CRB assessment in patients who may be eligible for emerging therapy targeting inflammation. With that, I will stop now and stop sharing and move to our speaker, Professor Khalid. He will address about inflammation and cardiovascular disease, what current trial we have, what we are expecting in the future. So, Professor Khalid.
Thanks a lot, Prof. Arafa. I would like to thank the sponsor and the organizers of this educational event. So I'll share my screen. You can see my slide, Prof. Could you see my slides?
We can see it, definitely, yeah. Thank you very much. We can. Go ahead, please.
Okay. I just wanna hide this upper panel. Yes, great. So my talk will be to carry on after Prof. Arafa's great introduction to the topic and to really say he has set the stage with very up-to-date data about inflammation and cardiovascular disease and how it is more common than you think, and it can make a difference. And I'll re-emphasize this issue in my talk, unlocking cardiovascular inflammation, high sensitivity CRP for risk stratification, and whether we're actually going to have a medical therapy that can improve outcomes based on this. Uh, Slide is not moving. Okay, so it's okay now. So regarding cardiovascular inflammation, we already know that myocardial disease, hypertension globally, that basically there are 788 million people are living with chronic kidney disease, something that I will emphasize in my talk. And the link between CVD and CKD, they have common interlinking, overlapping pathway. You can see uh, in the green circle here with the cardiovascular disease, and the pink one, the kidney, and then the blue is the atherosclerosis, and the how there are common risk factors overlapping among each other, and they're both CKD and CVD have overlapping risk factors, with inflammation being common and independent predictor of both recurrent ASCVD progression of CKD. And you can see there is a Venn diagram that basically they are intertwining with each other. You might have noticed recently in the last few years there have been more emphasis on linking these diseases together. We don't only treat cardiac disease patient versus kidney disease patient versus diabetic patient, so on. We have patients who have all these factors together. That's why recently there have been more emphasis on the CKM or cardiac kidney metabolic syndrome, and with the different stages of that CKM syndrome. And almost 5 million people living with atherosclerotic cardiovascular disease have also CKD and inflammation, and then currently no approved therapies for this subset of patients. So it's unmet medical need. How do you diagnose cardiovascular inflammation? Is cytokine-driven process predominantly mediated by interleukin 6, driving cardiovascular specific pathophysiology and adverse outcomes. And classically, you can identify it by doing high sensitivity CRP more than or equivalent to 2 milligram per liter. The cardiovascular inflammation, as I mentioned, is a key driver in atherosclerotic cardiovascular disease. And you can see here this diagram that will keep coming back to throughout the presentation, the NLRP3 inflammasome signaling. So once you have cholesterol deposition, hypoxia, neutrophil stimulation, and trapping in the plaque, you have this basically pathway that gets stimulated by the NLRP inflammasome, which leads to a cascade of stimulation of inflammatory pathway, and important inflammasome triggers in atherosclerosis, including oxidized LDL and cholesterol deposition. Something that has been always a debate: where does inflammation fits in? Does it really stimulate atherosclerosis, or it is basically a risk enhancer and moves on to really making the process even worse? But it looks like from basically basic science and lots of preclinical studies that you really need to have cholesterol deposition and hypoxia and to stimulate that inflammation process to start with. And this results in activation of interleukin 1 beta and interleukin 18 rather, triggering downstream pro-inflammatory signaling through interleukin 6, which induces the hepatic production. You can see here the end product that we measure in the lab as a routine clinical practice. Despite receiving guideline recommended treatment, many patients with atherosclerotic cardiovascular disease are at high risk for recurrent events, and cardiovascular inflammation is a key contributor to this risk. So keep this figure in mind, because the therapies that really target these different triggers in the pathway are really important. And where does the new treatment, ziltivekimab, will really fit into this pathway? So this is the figure again, and you can see interleukin-6 is a downstream cytokine of the NLRP3 inflammasome pathway, and increased interleukin-6 levels are associated with atherosclerotic cardiovascular disease and CKD, chronic kidney disease. The increase in interleukin-6 leads to endothelial dysfunction, cardiomyocyte hypertrophy, and coronary microvascular dysfunction, plaque vulnerability, kidney and cardiac fibrosis, and glomerular hypertrophy. So production of interleukin-6 contributes to cardiovascular inflammation and plays a pivotal role in cardiovascular inflammation, and leads to hepatic production of the CRP, what we measure in the lab. So CRP, basically, as you know, the standard CRP basically measures the CRP increase of more than 10 milligram per liter, and classically increase in those in infections, sepsis, autoimmune disorders, rheumatic disease. But high sensitivity CRP, as the name indicates, it actually measures trace amounts and even minimal amounts of CRP, less than 1 to 10 milligram per liter in the blood during a cardiovascular risk assessment. So it has a superior precision and accuracy and standardization, and that's why almost most lab now do the high sensitivity CRP rather than the CRP itself. Classically, if you have CRP more than 20, you're dealing with an acute infection or acute non-infectious inflammatory conditions. So usually what we're talking about, low to moderate levels of high sensitivity CRP associated with atherosclerotic cardiovascular disease, particularly those with chronic kidney disease. So once you go above really high levels, probably go and search for more infections or very acute inflammatory process. But those with atherosclerotic cardiovascular disease classically are not that high, not more than 20, usually in the range of less than that, 3, 5, up to 10. We have a plethora of data and a huge body of evidence from clinical trials suggesting elevated high sensitivity CRP associated with the risk of future cardiovascular events. You can see here from your left side the Jupiter trial, and basically apparently healthy men and women treated with rosuvastatin, the well-known Jupiter study. As you can see here from the graphs, the red color graph, rosuvastatin, reduction of LDL cholesterol less than 1.8 and low CRP, you get the lowest event. But in the middle graph here, the light blue color here in the middle, you can see the rosuvastatin reducing LDL by reduction of LDL, but basically still have high CRP and LDL more than 1.8, and placebo basically not on Resuva. And you can see here the best those who got both reduction on LDL and CRP. But if you have higher LDL and CRP, you have higher events. And then the prominent, the reduced, the strength trials that basically looked at the statin plus adding omega-3 or fibrates for that reason. And basically you can see here those who are less than 70 milligram per deciliter, i.e. controlled really LDL, and yet high sensitivity CRP, you can see their events are as high as those more than 70 milligram per deciliter and more than 2 milligram. So CRP has above and beyond prognostic factor. So it makes a difference. Even if you have controlled LDL less than 70, those who have high CRP, more than 2 milligram per liter, have higher event rate. The clear outcome here people with or at high risk for ASCVD, statin intolerant. Again, the same message, less than 130 milligram per deciliter, and yet high CRP have the same event rate of less than 130 and above, and CRP more than 2. And lastly, the CANTOS trial, the Kanakumab, people with history of MI and high sensitivity CRP have poor prognostic factor outcome compared to those with less than 2 milligrams. So this has been shown again and again in multiple trials, whether AMI or those with atherosclerotic cardiovascular disease. Once you have a high CRP, more than 2, it really correlates with outcomes. And this is consistent, the measurements of CRP and the LDL. So in Jupiter subgroup analysis, in the placebo, repeat measurements of high CRP, LDL cholesterol show similar consistency. So it's not just one snapshot measurements. It actually shows consistent measurements similar to the LDL. So it's not just a fluke or a play of chance. And the well-known study, the Nurses Health study published by Paul Ridker and the group, published a couple of years ago in the New England, with a single blood test done 30 years ago, very powerful, basically predictors of outcome. 30 years later, once they check their outcomes, the high sensitivity CRP, LDL, LPA, once each single one of them was high, you can see that increased hazard ratio. In fact, if anything, the high sensitivity CRP was actually the strongest factor, was 1.7 compared to 1.3 with LDL and 1.3 with ILP-a. The study also shows that the combination of these factors, if you have high sensitivity CRP and high LDL, or high sensitivity CRP and LP-a, or combination of these factors, the risk even goes higher with major adverse cardiovascular outcome, including MI, stroke, coronary revascularization, and cardiovascular death. This is a 30-year cohort study published in one of the best journals, medical journals. So it shows you how basically how important this prognostic factor. Reminding you, these are actually used to be nurses and followed up in the US system, and many of them actually got statins and got treated and so on. And despite that, high levels at baseline almost 30 years ago was very actually powerful as a predictors. And obviously, the lower CRP and the more aggressive the risk factors were controlled, and the lower CRP, the less their outcome, the less cardiovascular outcome was there. Not sure whether you heard about this funny term, SMRF. So SMRF stands for the standard modifiable risk factors, i.e. hypertension, dyslipidemia, smoking, and diabetes, and so on, and something called SMRFless. So again, Paul Ridker and the group basically last year at the European Society of Cardiology in August 2025 basically presented this, and they have shown that you have these SMRFless but inflamed women who basically have no risk factors, and yet they are at increased lifetime risk for atherosclerotic cardiovascular disease, despite having no standard modifiable risk factors. How many times you have seen patients who have no risk factors whatsoever, and yet they got an MI? Did you actually measure their inflammation, measure their high sensitivity CRP? And as you can see in the quantiles, the higher the obviously low, extremely low levels, as opposed to higher levels of once you go above 1, 2, and 4 milligram per liter, the higher quantiles, the higher risk. Obviously, you can see here the quantiles of increased 10% to stroke, 15%, and CHD 21%. The same thing goes as well for other risk factors. So that tells you that basically a lost opportunity, that assuming the patient does not have risk factor, and yet no one really measured their inflammation. And how reliable is high sensitivity CRP for really being a biomarker for interleukin 6? You can see here that in this study that will come back at the end for ziltivekimab, study that it is very good by a reflection of CRP, very good correlation between both of them. So high CRP is a good biomarker reflection of how high your interleukin-6 is. Now, does it matter? Well, yes, guidelines actually did change over the years from not really very strong recommendation to actually strong recommendation for measuring it almost routinely. You can see here from 2021, it's kind of uh, uh, as a shy level kind of recommendation to be for really measuring it or recommending anti-inflammatory therapy based on inflammation to actually having more stronger recommendation to the latest one in 2026 of actually recommending for a patient with ACS as a class 2B, which is controversial, but probably might be helpful. And we'll come to that in a minute. So you can see here in 2019, the American guidelines, elevated high sensitivity CRP is mentioned as a risk enhancer for ASCVD. But you can see here the latest European and American 2025 and 2026 and dyslipidemia guidelines got stronger recommendation for measuring CRP as a biomarker that can be considered as a cardiovascular risk modifier and mentioned as a cardiovascular risk enhancer. This is compatible also with our recent Saudi Heart Association position statement, which is actually in press that will be published very soon in the next few weeks. And we took a similar position statement that we recommended also CRP to be measured as a risk enhancer, particularly those with at high risk for cardiovascular disease. The high sensitivity CRP, more than 2 milligram per liter, indicates high inflammatory process, as we mentioned, and the clinicians, if you don't know it, you don't measure it, you're not gonna know the appropriate risk for your patient. So as you can see, as I mentioned, 2025 ACC scientific statement, among individuals receiving statin therapy, consideration should be given to increasing the dosage of statin into higher intensity if CRP is still high, irrespective of the LDL. So it does make a difference, even if the LDL of your patient is controlled. And even among individuals with established cardiovascular disease, high CRP could be a marker for recurrent events, even if the LDL is controlled. In fact, the European Society of Cardiology endorsed the SMART2 risk score that basically can see the different basically variables and included high sensitivity CRP as a risk predictor for recurrent events. As something that patients always ask you, دكتور ممكن يجيني جلطة ثاني am I at high risk for recurrent events? Well, one of them is CRP, and you can look up that SMART2 risk score. How we can then target inflammation, go back to this diagram, and we have different anti-inflammatory medications and therapies. You can see here the well-known colchicine, cheap drug, old, has been there forever. You have canakinumab that basically target interleukin 1 beta, and you have other basically inflammatory monoclonal antibodies that we're going to come to, but most importantly, the ziltivekimab. So to summarize the evidence in just one slide, because of the short of time, you can see here on the left side, the CANTOS trial published in the New England for canakinumab, and basically it did show cardiovascular benefit for the 150 milligram dose, and for those particularly who achieved a reduction in the sensitivity CRP, 25% reduction in MACE, but unfortunately increased risk of infection and modest reduction in the absolute risk reduction. So unfortunately, it didn't pick up and was not used really made it into clinical practice because of these issues. Modest, really absolute risk reduction and increased risk of infection. On the other side, on the right side, the methotrexate, the cardiovascular inflammation reduction trial, CIRT, low dose methotrexate was not associated with fewer cardiovascular events or reduction in high sensitivity CRP, so no clinical benefit. And then comes the colchicine, which was actually very promising at the beginning. The ColoCT, or ColoCot trial, and then Ludoco trial, the Ludoco and Ludoco 1 and 2, and there were actually good reduction, absolute risk reduction of 1.6, 2.8%. It was very promising and significant benefit, almost 31%. And we thought, well, finally, we got inflammation theory proven. But unfortunately, the recent trial, basically the largest one actually from McMaster, led by Sanjeet Joly, the clear synergy OASIS 9 showed no benefit in those with recent MI. So we're back to the head drawing board, and basically some controversial basically evidence about the anti-inflammatory basically medications. So the question here is what's the problem? Have we got this wrong? If we have shown that high sensitivity CRP has prognostic benefit above and beyond the usual risk factors and controlling LDL and so on, why then having these monoclonal antibodies or colchicine or methotrexate, very controversial evidence? If not, some of this was positive, some of this was negative. So something really missing in this evidence generation. Maybe we need to have different agent, not necessarily that the hypothesis is wrong, but maybe we need a better monoclonal antibody that really targets interleukin 6, which will be really the main really objective in the rest of my presentation. So to remind you, interleukin 6 is a downstream cytokine of the NLRP3 inflammasome. I already mentioned that's a very powerful contributor to cardiovascular inflammation. It has been shown in large-scale human genetic and biomarker data, in Mendelian randomization data on the right side here, with thousands of patients from the UK Biobank. So very important prognostic marker that has been shown in the huge UK Biobank, almost 408,000 people, that basically individuals with high interleukin 6 and LDL levels basically have increased events. This has been shown in multiple studies, and that has been shown in the physician health studies and the CANTOS trial, increased risk of future MI events and recurrent events. Not only that, the lipoprotein little a has been getting a lot of attention in the last few years, and we're waiting the Horizon trial at the end of the year 2026. Hopefully, we'll have the first treatment for lipoprotein little a. This is a new publication that was just published in Atherosclerosis Journal, and it shows that in a huge database, again, UK Biobank, in more than 34,000 people, and those with atherosclerotic cardiovascular disease-free participants, and 13 with a median follow-up of almost 13.6 years, elevated LP(a) was associated with increased major cardiovascular events only in those with above median interleukin 6, has a ratio of 1.17 up to 1.8 as a confidence interval, but not in those with below median interleukin 6 with a high significant p-value, with a conclusion that inflammatory milieu captured by interleukin 6 identifies the context in which LP(a) may translate into higher cardiovascular risk, which is very interesting and very important in the interpretation of the Horizon trial later on when it comes back as positive, hopefully positive trial. Are we going to have an overall positive trial, or on those only who have inflammation? So that gives an impression and a clue. Maybe in lipoprotein little a is important only those with high CRP or interleukin 6, and maybe it works only on those who have inflammation. So to finish, overview of ziltivekimab, it's a human IgG1 monoclonal antibody directed against the interleukin 6 ligand. It's an anti-inflammatory agent administered once monthly as a subcutaneous injection. and showed promising phase 1/2 results that have the potential for maximize efficacy and safety compared to other inflammatory agents. So basically, it basically goes into that middle part of the pathway, more upfront, and not in the very beginning of the 1 beta like colchicine and others, but in the most important, what we think most important player in the inflammatory pathway before CRP, targeting specifically the interleukin 6. So this is the ziltivekimab phase 2 trials. Basically the rescue study design of 264 patients, stage 3 to 5 CKD, chronic kidney disease with high CRP, randomized to placebo versus ziltivekimab 7.5, 15, and 30 milligram subcutaneous injection every month, with the trial objective seeing whether we'll actually have reduction in the CRP. And indeed, it did show and achieve the main objective, demonstrating significant high CRP reduction for all doses of ziltivekimab, median reduction of 77, 88, and 92% respectively. So the higher the dose and the more reduction in the CRP, and response sustained throughout the end of the treatment, and clinically meaningful and statistically significant reduction in the markers of atherosclerotic cardiovascular disease, such as fibrinogen, haptoglobin, and others. And no safety concern, very low rates of 1.5% of neutropenia, low rates of thrombocytopenia, no increase in liver enzymes, just a minor skin reaction. And safety was similar to placebo. This is very important because, as I told you, the CANTOS trial, the canakinumab, showed increased risk of infection. So this is very reassuring that we're not getting really a red signal or a concern for increased infection with this monoclonal antibody. This is the phase 3 cardiovascular outcome trials, the ZEUS, the Hermes, and the Artemis trial. ZEUS will be over 6,000 patients. Patients living with heart disease, kidney disease, and cardiovascular inflammation. Hermes in heart failure with mid-range and ejection fraction and HFpEF, preserved ejection fraction, 5,600 patients. Patient living with heart failure and cardiovascular inflammation. And Artemis trial, the 10,000 patients who have experienced a myocardial infarction. The one that you're going to be looking for is the ZEUS, which basically at the end of this year, by November, during the American Heart Association. That would be really a big blockbuster, as you can say. If it turns out to be a positive trial and without really increased risk of infection or concerns about safety, I think finally we will have an agent that finally will hit the inflammatory hypothesis and prove it that it is true that targeting specific anti-inflammatory agent against interleukin 6 is the way to go, and we got the inflammatory hypothesis correct finally. So this is ZEUS, 6,376 participants, serum high sensitivity CRP more than 2 milligram per liter, established atherosclerotic cardiovascular disease, and chronic kidney disease defined as following eGFR more than 15 but less than 60. And basically, the objective is to demonstrate the superiority of ziltivekimab 15 milligrams subcutaneously once monthly in reducing the risk of MACE compared to with placebo, with a very hard endpoints. Primary endpoint, time to first occurrence of 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke, with other secondary endpoints. So very powerful trial with very hard endpoints. So in summary, these are the take-home messages. Despite advances in the treatment of cardiovascular disease, atherosclerotic cardiovascular disease remains a leading cause of death, particularly people who seek chronic kidney disease. Cardiovascular inflammation, predominantly mediated by interleukin 6 activity, leads to adverse cardiovascular outcomes and renal outcome. I've shown you that there are a lot of overlapping pathways, and in fact, now there is a CKM syndrome, the recent position statement released by the American Heart Association. I really urge you all to look it up. Despite standard of care globally, up to 50% of people with atherosclerotic cardiovascular disease and CKD may show evidence of cardiovascular inflammation, identified by high sensitivity CRP more than 2 milligram per liter. Treating cardiovascular inflammation by targeting interleukin 6 inhibition may reduce MACE, cardiovascular death, and CKD progression. And in this phase 2 rescue trial, we already shown a basic sign trial that basically that we do have anti-inflammatory response by reducing interleukin 6 significantly and did not raise safety concern. Hopefully, in the ZEUS trial by the end of the year, has the potential, ziltivekimab has the potential to be first-in-class interleukin 6, targeting cardiovascular inflammation and reducing cardiovascular events in people with atherosclerotic cardiovascular disease and CKD. A very tough group and very, very tough kind of patients, really, in the clinic, as you know, and very high risk for events. Very smart hypothesis by the investigators, and as being evaluated in this landmark phase 3 cardiovascular outcome trial. Thank you very much for your kind attention, and the mic is yours. I have to say, please kindly scan the QR code that Prof. Arafa has shown you at the beginning, so we can have before and after questions to assess your response after those two talks. Thank you very much for your kind attention.
Thank you, Professor Khalid. Thank you very much indeed for this very, very remarkable really explanation about the inflammation role and the future for the management. So let's open the floor for discussion. And till we have some question from our attendee, we have really 265 people around here, physician and intestinal topic really. So it's very, very good attendee. I hope you have a few questions from them. Let me start you in your practice currently, Professor Khalid. For whom you do check the CRB, has the CRB, which patient do you think we should start checking from now till we have the right therapy available?
Well, hello?
Yes.
Could you hear me? Yes.
Yes. Yeah, we hear you. Yeah.
So I do it routinely. So I do it routinely in my patients, particularly those with cardiovascular disease, but even those with risk factors. So I really do it routinely in my patients. Sometimes I tell my students that I turn my clinic into research lab. So I really try to learn from my clinical practice. So I don't only present data and so on as a researcher, but I also try to learn from my patients. So that's the only way to learn, is to actually do the test and basically see how this actually changing your practice. And I have seen it actually change it. I have to say, in around 20% or so, it might change my clinical practice by giving more aggressive statins, more risk reduction in patients who have high CRP, despite controlling LDL.
Great.
Do you
Uh, Yeah,
do
we do
you
actually. We do it routinely for patient. The problem that this high sensitivity CRB is very common both in those who have established already cardiovascular disease and those who are at high risk as well. So we have a widespread group that need to be really evaluated ahead of time in order to prevent the happening of these acute events, the cardiovascular mortality. One question here from the attendee say, how frequent should we screen for HSCRP in acute coronary syndrome? I mean, we do it on admission, but how we will check it after that? We will see how it's going, coming down, or how frequent you check it?
Yeah, it's true. I mean, in acute MI, as you know, it will be very high, so it might not be very accurate. In fact, even lipoprotein little a, for that matter, it can be affected by 20%. So it's advisable to repeat it again after the patient has gone home, and to see whether the patient have still persistent inflammation once the patient settle down. This
Okay.
is how we do.
So now in your practice, let's say you did today a patient who's at high risk and you found it to be between 2 and 3, the L level. What you would do nowadays? I mean, as you said, we increase the statin, we increase the risk factor modification. What can we have anything else to be done, or just the usual intensification of medical therapy?
Yeah, the usual intensification and other make use of this to counsel the patient more properly. Stop smoking. Some patients say, "Well, why still I have this kind of low levels of inflammation, although they are not complaining of anything?" And is it the stress level? The Because if you controlled everything, why you still have that low grade inflammation? And I tell my patients, well, maybe you need to have more aggressive exercise, stop smoking, reduce your weight. Obesity also is a big thing as well. I think it's not only the cholesterol, it's other things as well, as you mentioned, Prof.
Yeah, great stuff. Now, I think this is too early to judge, but from your estimate, how the coming treatment will reflect on our management if it's coming to be a positive trial. I mean, I think that will be a big major change in our life, or our patient management, if the result to be positive, the US trial in the future.
Well, great question. The company asked me the same question. What's your prediction? But the I think the design of the study was very smart. They took the highest risk patient. This is as high as it gets. You have somebody who have both atherosclerotic cardiovascular disease and CKD, and basically you try to reduce the outcome and very powerful hard outcomes, 3-point MACE. Uh, my prediction, it will be positive, but hopefully it will be positive enough to be used in clinical practice. I hope we're not going to repeat the same Cantos trial. You have a positive trial, but it's modestly positive. So yes, you have a 20% relative risk reduction, but when you calculate the absolute risk is around 1% or so or less, and you have a high risk of infection. The good thing about ziltivekimab, as I have shown you in the rescue trial, in the basic science trial, it did not. There were no signals for increasing risk of infection by assessing neutrophils and other things. So hopefully it will not induce infections, and hopefully, obviously, the elephant in the room is the cost. So basically, yes, you have a positive trial. It did not increase the risk of infection, but it's very expensive. And we have been really, we know this from you know this, I know this from the dyslipidemia injection trials, that we have very good agents, and yet we go into daily struggle with the insurance companies, and even in government hospitals the drug is not available, the drug is expensive. And this is what I told the manufacturer: please don't make it very expensive if it is a positive trial, because we want patients to really have really access to it. Otherwise, if it is positive trial and you no risk of infection, you don't want something to be very expensive. Otherwise, we'll go back to square zero again, and patients will not really have access to it. So I think it's a combination of factors, not only being positive trial and relatively safe, but I think we learned from the dyslipidemia injections trial, the evolocumab, alirocumab, and inclisiran. Yes, they're excellent medication. They have niche and so on. But I think you and I go on to daily struggle with the insurance approvals that really insurance do not really approve it on swiftly if you have very expensive drugs.
The same for the injectable form and the other medication for chronic diseases. Do you think this would be a lifelong therapy treatment, or will you just, let's say, you would treat the inflammation, and the patient will have back to CRB to normal, and then you will stop medication, or it will be lifetime therapy?
A great question. I believe it will be lifelong therapy.
And this is a problem.
I
Yeah.
think medicine is going into this reducing the lots of pills and going into these monthly injections. Hopefully, we'll have gene editing as well. You have seen that new publication of
Yeah.
gene editing for
Yeah.
the cholesterol and so on. But I think medicine is going trying because of the polypharmacy and adherence and so on. This is where medicine is going. Basically, if we keep adding pills and adding pills, I think we're going nowhere. I think people will just you have seen people stopping medicines. And as we always say, medications are good as long as patients take them. So
Absolutely.
you basically you show me a positive trial, but patients don't take them either because they are very expensive or they have a lot of side effects and so on. So as long as you have but having a positive trial is just the beginning. The question is the cost, the side effects, and so on, many other things. Because remember, this is going to be another seventh drug or ninth drug in some of the patients. It's not easy to really add another drug, and really, unless you have really major outcome. If it is modestly beneficial or some sort of slight reduction in outcome, and a very expensive drug and costly, it's not going to be used.
Absolutely right. Absolutely right. Absolutely right. Now, meanwhile, again, just going back to the basic of this, we learned from many years before that if you target more than one thing in the same time, you get better outcome. Like if you target LDL, you target CRB. So, yes, I want to convey the message to to the physician and to the patient as well that it's not a simple thing that we say take this medicine and that's it. We need really to follow our patient up to know where we are. So how we think that the now once we give the treatment, it's really that we will expect the patient will be followed up every 3 months, 6 months to see the response, or how yes, I'm trying to imagine how the patient will be managed in the future with this treatment.
True, true. How frequent it is would be interesting to see how quickly this in the Zeus trial, basically the CRP has dropped. I've shown you it has a very good correlation with interleukin 6. So I would imagine that uh, you should get a response very quickly within in terms of affecting the biomarker. So within a couple of weeks to 1 month maximum. And the higher the dose, obviously, the better. But the trial will really answer your great question, will tell you how frequent we should follow patients, because in the trial, it will show you now we're moving into a clinical trial. So rather than just at the bench, it will show you how patients, those who hopefully showed good outcome, how frequent you should check it. But I would imagine it will be probably repeated in a few weeks and then every 3 months, the usual practice
Yeah,
with every
yeah,
routine follow-up.
great, great. Trying to see whether we have any other question from the group. Meanwhile, I'll continue to ask you because it's really a good chance to have you, Professor Khalid, on board because really we learn from you a lot throughout. So I'm
انت
glad.
استاذنا ابو اسامه.
Allah يعافيك. Now, basically, as you know, that why you think that this time will we succeed? Are because we are targeting our treatment to a certain molecule, interleukin 6. Why do you think this molecule will be successful?
Well, hopefully it's a very specific molecule against interleukin 6. So CRP, maybe it is just downstream, and as I have shown you, it's a very mixed result. So there's some sort of good signal that targeting inflammation works. So let's not put a very blank statement that inflammation is the anti-inflammatory hypothesis was totally wrong or was actually negative. There was some positive trials. The Cantos trial was positive. The colchicine, two trials were positive. But for whatever reason, the clear synergy was negative. Now, Sanjit Juli from McMaster was asked, well, is that the last nail in the coffin, so of the inflammation? Because basically some criticism to the clear trial saying, well, you did not reduce CRP in the clear synergy trial enough.
Yeah,
So
yeah,
maybe the colchicine did not work properly by reducing the CRP. So maybe we need a strong anti-inflammatory like ziltivekimab without increasing the risk of infection to get that balance. So one criticism for the clear synergy, well, CRP was not reduced enough. That's why you got a negative trial, while
yeah,
it was reduced in the previous trial. But colchicine, although it is cheap and so on, but as you know, it has diarrhea, has side effects and so on. But unfortunately, that got colchicine to a grade class 2B, so it's not recommended to be given, routinely in the latest guidelines. So we go to the drawing board as we discussed and saying, well, maybe we need a strong, very specific, and yet very specific interleukin 6 therapy that really get this balance very well. And let's stay tuned and see whether this hypothesis will prove correct or not.
great. We have one question from the attendee, Dr. Targ, saying here, my wife is having CRB positive since 13 years. With other all parameters normal. Her weight is about 100 kilo. She's 39, type 2 diabetes with normal, with good control. So, what advice for the question
Well,
here?
very
What is,
interesting.
yeah,
Very high CRP, very long CRP for years, huh? So the question how high it is.
yeah,
Uh,
yeah, yeah.
the main thing is to make sure that she doesn't have connective tissue disease, inflammatory pathway. I have a patient who consistently have high CRP, and we discovered that basically she has sacroiliitis.
Okay.
So she will always have, unless she gets that injection, cortisone injection, or it could be a biomarker for some sort of connective tissue disease. So my first advice, just make sure that she doesn't have, she gets seen by a rheumatologist, do the full inflammatory, the full connective tissue disease workup, and she doesn't have sacroiliitis or other chronic musculoskeletal pain, fibromyalgia, and so on. And if she's middle age, I would do lipoprotein little a. If she's 40 and above, I would do CT calcium score as well, whether she has risk factors or not. Just make sure she doesn't have plaques in her coronaries. If others are all negative, what would you do, Prof. Araf?
Well, I agree fully with you. I mean, she's 39, she's diabetic, she's at risk factor. I know she had good control, but we know diabetes still is a major risk factor. So I would go for calcium score and see lipoprotein little a to see what's going on there. Yeah, and
And
definitely look.
more
Yeah,
aggressively controlling her
yeah,
LDL.
yeah, yeah. Uh, Finally, we have one last thing to say. Thank you, Professor Khalid. We need to take a home message in one or two lines only. What you would tell us at the end of your talk?
Yeah, I think inflammation is important. CRP, you need to really introduce it into your practice to learn more about it and to learn more about your patients. We have no proven therapy so far. We hoped that colchicine would work. Unfortunately, it turned out to be a negative trial according to the latest WISIS 9 trial. We're hoping that will zitifikamab, the very specific interleukin 6 agent in the ZEUS trial, hopefully in patient with CKD, by reducing interleukin 6 will have positive outcome, and hopefully that will prove have for the first time a specific agent for inflammation. I'll be interested to know, Prof, before and after that QR code. I'm not sure whether the organizers would like us to show. Did they collect any responses before and after? Did people change their practice based on this, or are we going to see results for their for their
I
answer
have
to the
no
question?
clue actually if they can help us with this regard. Do we have any?
Feedback or something?
Seems to be no.
Yeah, maybe the company will collect
Yeah,
the
we'll
uh, the
in
feedback.
another meeting we will discuss it together. Well, by
Obviously,
that I will.
for that
Yes.
last question about that chronic inflammation, if everything is correct, if everything is aggressively treated with statin and no connective tissue disease, and LDL is aggressively controlled, you might want to consider and LPA is normal, and doesn't have high CT calcium score. She might want to consider colchicine, but otherwise, really look for aggressive lowering of LDL. Make sure she doesn't have inflammation or connective tissue disease and other things. If she does have high lipid, I have shown you that study from the big database from UK Biobank that you have higher risk for atherosclerosis if her LP little a is high. So you might argue to have more aggressive LDL, less than 55 milligram, if her LP little a is high as well.
Right. Well, thank you very much, Professor Khaled. Thank you really for this very, very impressive presentation today. Hopefully, we'll meet you in the future in more meetings. And thank you, Saudi Heart. Thank you, Norvadisk, for your sponsoring this meeting. And all the best luck for our colleague who are, mashallah, good number. Up to now, we have 271 with us on the line. So all the best luck, and we'll see you in another meeting. And assalamu alaikum wa rahmatullahi wa
شكرا
barakatuh.
سلام شكرا بروف عرفة، يعطيك العافية.
Salam.